months, you should be able to remember this. All right, well, thank you, Dr. Brown.
You're welcome. Okay, guys, we're going to finish off on neuro, but I'm not going to go at such a rapid pace to catch up. It's going to make no sense. We'll go at our usual pace, but we don't finish covering today. I will then, in the office this afternoon, narrate and post, okay? So we're not going to go so quickly. Just a couple things about 426 for next semester. That's medical surgical leadership. Your med-surg clinical, traditional groups. For those of you that aren't going to be part of the independent practicum. Dr. Moran and I are putting our heads together about what we can do to add structure to that, build on what you've learned here and carry it into that so you don't forget it all. Last year we did SBARs and KSAs. You've already done them. They're looking beautiful. If you haven't heard from me, it means that what you gave me looks good and you don't need to change it in any way. Probably a reflective patient advocacy paper, but I'm looking at some more collaborative learning activities that build on some acute clinical scenarios that require strong decision making. Multiple organ system failure, for example, so that what we're thinking of is some topics based upon this course that you can carry into the clinical next semester, in which you can do as a group during your clinical day or in post-conference. I think that will have some more meaning for you and build on what you learned. It might mean a couple short narrated and posted lecturettes on multiple organ system failure or septic screening that you can listen to, and then as your clinical group moves into the collaborative activity based upon that. So if anybody has any ideas or would like to help me draft that out, doesn't mean you're going to get the answers, but just let me know. Okay, let me quickly pull this up. Course documents. Okay, next Monday will be the neuro test based upon the neuro lecture only. Get last week and this week. Nothing else but neuro. 60 questions, the usual fashion. We will have a collaborative. Okay. I figured let's get neuro over with. Oh, crud, what's going on here? Before the holiday. All right. Okay, there we go. Course documents. Okay, as we open this up again, Monday after the holiday will be vascular and the short lecturettes on basic hemodynamics and the short lecturette on vents. We then have 2 lectures left. 2 lecture dates. That will be the 7th and the 14th. This is what I propose to do, is on the 7th we do endocrine. On the 14th we do ortho. I've just come to the realization that you guys haven't had a strong ortho exposure, so I'd like to give that to you before you leave my time. And then recorded on skin and burns. Burns will mainly be an awareness thing, with the exception of a couple basics. What can cause it? How do I measure it? Both size and depth. How do I know this patient needs to be referred off to a center? Patient who's at risk for smoke inhalation. Patient who's at risk for burn shock. The rest is awareness only, but because it involves very high level nursing, and you'll get there, but that's not something for this year, okay? All right. The skin, we'll talk about some basic things such as scleroderma and how that affects other organs and so forth. So we'll get that going. Oh, come on here. The final exam, I need to verify the date. It usually is the last Friday afternoon of finals week. And it usually is 2 hours. I propose that we do at least 75 questions. That way, you know, if you miss some, they're worth not as much as if there was only 50 questions. So that gives you a little bit of padding. In terms of the final exam, the bulk of the nitty-gritty on the final exam will be on what has not been covered in exams 1 to 4. All right. The other stuff, yes, it has to be comprehensive. But if I ask you any cardiac questions or respiratory, they're mainly going to be general concept questions about the general management of that kind of patient. I've already pulverized you with test questions on that. So the bulk of the questions and the bulk of the detailed questions will be on the things that have not been covered through exam 4. Okay? And there might be 3 to 5 questions on cardiac and 3 to 5 on respiratory, but there'll be general concept questions, general management questions. Okay, not as nitty-gritty. Okay, for those, come on here, course documents. Okay. For those of you who have time and want to come this afternoon, afterwards, after this, we'll meet at 3:30 upstairs in Gowan 200. If you want to do some practice test questions, we're mainly going to do general questions so that we can get into how to rip questions apart, identify those tricky words that often lead you astray, and then how to rule in and rule out answer options. I know some of you go into PEDS this afternoon, so we'll hang around on Friday after Hearst review, probably the same room, Gowan 200. We'll do the same. So if you can't come this afternoon, you're not going to miss out. We'll do both sorts of things. Okay? It is optional. Here we go. Okay. All right. Any questions before we start in on stroke? All right. Yes.
What day is the final exam?
I'm going to verify that. It's usually Friday, the last week, and exams are the 15th. Through Saturday the 19th, so it will be probably the afternoon of the 18th. But I just want to verify that.
Stage that said it's the
18th is usually that slot, and they usually don't change that slot. I targeted with Professor Taylor last year. Okay, so plan your travel plans. I wish it was earlier in the finals week. They do not change final exam dates, so plan your travels accordingly. Okay? Yes.
I'm pretty sure the 14th isn't a class day.
The last day of class is Monday, December 14th. The 8th is not a class day. That's the Immaculate Conception's reading day. You don't have class on the 8th. That is reading day. And that is also the Feast of the Immaculate Conception. But the last day of class, according to this academic calendar, is Monday the 14th. Okay? All right. Okay, let's move into strokes. This isn't, hopefully, but correct me if I'm wrong, this shouldn't be the first time you hear about stroke in the classroom, okay? And hopefully you guys have also had some stroke patients in clinical as well. When somebody's had a stroke, it means that blood flow to brain tissue has been disrupted. It has either been disrupted because of an occlusion, such as a plaque, similar to a plaque in a limb due to a peripheral arterial disease, or a plaque in the coronary artery. In this case, it's a plaque in one of the arteries of the brain. Okay? Same kind of plaque buildup, it's the same process, the same risk factors, and just like in a plaque affecting the flow through a coronary artery, that the myocardial tissue that should be perfused is not, same thing here. That area of tissue that is underperfused gets damaged, just like in a myocardial infarction. So that's why these are often called brain attacks. That's a British term for them. Okay, instead of a heart attack, it's called a brain attack. If that obstruction, that disruption, leads to neurological symptoms that last more than 24 hours, that is classified as a CVA. If that disruption in blood flow leads to symptoms that are temporary and last less than 24 hours, that is called a TIA. That's a warning stroke. It usually means that a small artery has been occluded, or that the occlusion isn't 100%. But if you have a TIA, that greatly increases your risk of having a full-fledged stroke. Okay? So if neuro deficit exists and stays more than 24 hours of stroke, less than that is a TIA. The degree of damage, the degree of paralysis, of speech or swallowing that's affected, will be determined by the size of the brain tissue that went without perfusion. So no two stroke patients are going to have the exact same symptoms. It depends upon the location of that affected brain tissue and the size of the artery that should have perfused this size of brain tissue. Okay? So some people will have some degree of hemiparesis, others will have extensive hemiparesis. The symptoms and intensity will not be the same patient to patient. Okay. Two kinds of strokes. Ischemic means the occlusion, the clot, plaque. Hemorrhagic means the artery was not occluded, but it ruptured. And because that artery ruptured, the distal brain tissue goes underperfused. It's real important upon admission in the ED to try to narrow it down to which kind of stroke, because if we believe this is an ischemic stroke due to a clot, then we can involve fibrinolytic or thrombolytic therapy. It's the same thing. But God help us if we give a clot buster to somebody who ruptured an artery. Okay, so we really need to fine-tune which type of stroke it is as fast as we can. The majority of strokes are ischemic, so the minority are those that are due to the arterial rupture. We're going to talk about cerebral edema a little bit more later on. A small percentage of strokes do result in cerebral edema, especially if they were massive. The risk factors for stroke are the same as those for peripheral arterial disease and for coronary artery disease. Let me just do this one slide. Okay, here's your two types of strokes. Can you see the hemorrhagic, the rupture of the artery? In this case, there might have been an aneurysm or something called an arterial venous malformation. What that is this abnormal cluster of a mixture of arteries, of tiny, tiny arteries and tiny veins. And it looks like, almost like a ball of yarn. Very, very difficult to resect them out surgically. In many cases, you don't even know you have one until it blows. It can be congenital in nature. Okay. So if somebody in the family has it, others in the family should be checked for it as well. You usually find, and then all of a sudden the AVM blows, and you're not fine. They can clip it. If they know you have one, they can actually go in and clip it on either side, so that even if it ruptures, it's the blood, the damage is restricted. Okay? So here we have a hemorrhagic. Obviously, that blood is going to be space occupying, so this patient's going to have a higher risk for increased intracranial pressure and cerebral edema because this blood is space occupying. This is the most common. We have a plaque which disrupts blood flow, similar to an MI. This area of brain tissue goes without that blood flow, becomes ischemic, becomes dead, becomes useless. Any function that correlates to this part of the brain will then be lost. Be it mobility, be it cognition, be it speech, be it personality. Okay? Similar to that. Okay, remember, thrombus means clot in place, which means that clot built up, it's in its original location, it just got large enough to block. Emboli means that is a clot in movement. That is a fragment of a thrombi, which then got put into movement and went as far as it could go, and when it couldn't go any farther because it got lodged in a tiny artery, then it does its damage. Okay? We can do, if we get it early enough, we can do, when I say fibrinolytic, it's the same thing as thrombolytic, okay? When we get these folks early enough, we can give them that clot buster drug. Dissolve these pieces of clot, restore perfusion on the other side of the clot. That is remarkable, but we've got to get to them early enough. Fortunately, the bulk of the clots fall into this, the bulk of CVAs fall into this category. Here's your hemorrhagic. Obviously, you don't want to give a clot buster to these folks. You'll kill them, basically. Okay. And you see this blood, which is arterial in nature. So it's going to come out, pulsate, and it's going to fill up quick. It's space occupying. These folks have a much more difficult task, recovery ahead of them. They're going to have increased intracranial pressure. They probably will have cerebral edema as well. Okay. Manifestations. There are some common ones, and then there are some non-common ones. Most often, these symptoms are not insidious. They come quick. So sudden onset of neurological symptoms, meaning movement, meaning sensation, meaning speech, meaning swallow, meaning cognition. Okay? Sudden onset of neurological deficits. If the deficits last longer than 24 hours, it's a stroke. If they're temporary, less than 24 hours, that's a TIA. In many cases, you have some slurred speech or speech that doesn't make sense. Now, affected speech is called aphasia, but there's two types. There's aphasia that's receptive or aphasia that's expressive. When they have receptive aphasia, that means they can't understand what you're saying. That part of the language, remember language is two-directional? That part of the language, it has been cut. So they can't understand what you're asking them. They can't understand what you're saying. But their speech end of the language continuum is intact. And they'll respond to you in a sentence that's a full sentence, a very articulate sentence, but absolutely makes no sense to what you ask them. So their problem is receiving information and turning around and responding to that. The most common kind of aphasia is actually expressive aphasia. That means they hear you clearly, but they can't answer back clearly. They answer back slurred, or the words are put in crazy order, or they make up words. Okay? And they quickly learn to just limit to yes or no. And sometimes all they can say is no, but you have to understand which no is no and which no is yes. My aunt had one of these, and when she said no, 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 that meant no really. And when she only said a single no, that meant yes. Okay? So that's sometimes commonly what you see. Hemiparesis means weakness on one side. The intensity of that will vary from patient to patient. Some people might have mild hemiparesis. They can still use their hand, for example, but not for fine motor. They can use it for gross motor. And then other people, that whole arm is just dead to the world. Blurred vision, this is common. Blurred vision, double vision. And you know what nystagmus is? Your eye just shakes. Okay? And then they usually, ones with the hemiparesis, on the same side of the hemiparesis, you'll see the facial drooping. So all of a sudden, one side of the face is lower than the other. Okay? They'll smile with one half of the mouth, but the other half of the mouth will droop. The eyelid will droop. And on that same side of the facial drooping, the shoulder will droop. Okay. Sylvester Stallone, the actor, was a victim of a difficulty during birth. Forceps were used, but they did damage to the side of the face. So if you look at a picture of him, he's got that strange smile. Half his mouth is half of his face is paralyzed. So one eye is lower. He can't move one side of his mouth. He talks out of the other side of his mouth. That's similar to what you'll see. So if you see this facial drooping, ask them to smile. And if they can't smile with both sides of their face, then you know there's issues. You ask them to shrug their shoulders, and if they can't lift up one shoulder, the same side of the face, then you know that there's some issues. Decreased level of consciousness, they all don't go unconscious. Some people actually arrest when they code. Other people just kind of get dizzy or drowsy. Some people also complain of serious headache. And they may seize, particularly if it is a hemorrhagic stroke, space occupying. But both kinds of stroke can seize. we come up with this new, you'll see this everywhere. You see this all over the buses in Ireland, for example. To note, if you think somebody's having a stroke, think fast. So F stands for changes in the facial appearance. A stands for can they move their arms, which means that, hemiparesis, plus the shoulder sagging. Can they speak articulately? Can they understand you? And then time is critical. So if you see any of these first symptoms, the first 3 symptoms, you need to get somebody to the ED. This is a stroke in evolution. Now, there are some symptoms that differ between right-sided and left-sided. I'm not going to hold you to those. You're not a neurologist. Just be aware that there are changes. Okay? As a nurse, you're never going to be put in a position of diagnosing a right versus a left-sided stroke. Just be aware that there are some changes. Also be aware that if the brain damage affected is on the right side, what you'll see is changes on the left side. There's a crossover. Okay? Okay, so here, this is the most important here. Right brain damage, left side weakness. Left side brain damage, right side weakness. So the damage crosses over to the other side. Okay, so of all this slide, this is the most important thing I want you guys to remember. In terms of treatment, first thing, of course, is your ABCs. Depending upon the size of the stroke, the location of the stroke, their vital signs can be affected. If anything, you may see very high blood pressure. That is a risk factor. Could also be a causative factor. Depending upon the stroke, you may also see changes in heart rate. And with that, and of course with the hemiparesis, changes in gag and changes in airway patency. Okay? So ABC's rules. Close monitoring. The size of the stroke will depend whether or not they go into the ICU. In a busy tertiary unit, they may go to the IMCU. For example, the IMCU at Fairfax is probably like a community ICU anywhere else. Okay. So which unit they're admitted to depends upon the capability of the institution and the severity of their presentation. If they are very severe, then they'll be in the ICU. And then they're assessed for, was it an ischemic stroke? How long has it gone in time since the onset of their symptoms? If their symptoms occurred 3 days ago, it's too late for fibrinolytic therapy. But if their symptoms started an hour ago, and we're positive this is an ischemic stroke, then we can get this fibrinolytic therapy on board, try to minimize this, dissolve the clot, minimize the damage. Okay? And then they're put onto some precautions. Definitely aspiration until speech therapy rules that they've got a good gag. Definitely seizure risk until the severe part of the stroke goes by. And then they're going to need a team to get them back into recovery. This is life-altering, so you need social service. If they have any kind of hemiparesis, you're going to need PT and OT. You're going to need nutrition, and you're going to need speech therapy if there's any problems with their gag, their swallow, or their speech. So they're team managed, and that works out for best patient outcomes. Mm-hmm.
Is there a certain time limit for when you have, like, your last option to use the fibrinolytic?
I think it's physician-driven, but it's similar to what we talked about with cardiac. Okay? But it is, in my experience, it's physician-driven. Okay. Obviously, if you've got a 21-year-old, they're going to be a little bit more aggressive than an 89-year-old with a long list of comorbidities. So in that one, they might take more of a risk. Okay. Then there's massive strokes and mini strokes. You hear of patients that have a mini stroke. Some of the actors have had mini strokes. Halle Berry has had a mini stroke. Okay, and then there's massive overwhelming strokes. The TIAs are really warning strokes. Okay. They are not to be ignored. Just because the TIA goes away doesn't mean that the underlying problem has gone away. The underlying problem is very much in existence, and it will come if you don't do anything to turn it around. Okay, so TIAs are temporary blockage or blockage that is not 100%. So there eventually is quick reestablishment of perfusion, or only a small area of brain was affected. Okay? Any questions on strokes? Okay. Yeah.
What's the drug therapy going to look like for a hemorrhagic stroke? Just giving them like
Hemorrhagic stroke. The big thing with hemorrhagic stroke is you've got to stabilize them. You want their blood pressure normotensive. If it's too high, you can expand the size of that rupture. If it's too low, they're already losing blood. They could go hypovolemic on you. You also have to treat them for increased intracranial pressure and cerebral edema. And once they stabilize and that clot starts to thicken into, that blood thickens into a clot, they usually go in and evacuate the clot out. Okay? So your issues are not so much medication, but volume, minimizing edema and increased ICP, and going in and getting that hematoma out of there. They have a greater need for ICP monitoring. In some cases, they can drill a burr hole without opening up the whole skull. They can drill a burr hole, evacuate that hematoma out, put a bolt in place, and then monitor them through the same hole. Okay? Is there another hand up? Yeah.
Can you just clarify the fibrolytic therapy again? So
Of the what?
The fibrolytic therapy.
Fibrolytic therapy is not anticoagulant. Anticoagulants like heparin and Coumadin prevent clot development. They will not dissolve a clot. Aspirin doesn't dissolve a clot. It just lets platelets slipper over each other so that they don't create one. Fibrinolytic therapy are clot busters. They actually decrease, they can dissolve a clot over time, and they can do it quickly.
Can you clarify
And the one,
time frame?
it depends upon the patient and the clot, but within hours, okay? But the one that we tend to see most of is something called TPA, tissue plasmin activase, which is what we talked about in cardiac. There was another drug that we used to use when these things first came out, and that was called streptokinase. And it was an enzyme that was developed off of the strep bacteria. But it had a lot of side effects to it, nasty side effects, and people reacted to it. So you might see streptokinase still on the list, but what we would use would be TPA. Okay. Same for cardiac. Okay? Okay, let's move into TBI, which is traumatic brain injury. A lot of these guys are coming back from Iraq and Afghanistan with this. TBI is traumatic brain injury, and that can be either an open injury or a closed injury. An example of an open brain injury would be gunshot, impalement, stabbing, anything that results in an open skull fracture, for example. In TBI, you often have fracture or penetration of the skull. And the injuries can vary from a mild concussion to just a massive gunshot wound that's overwhelming. We're going to go through some of these individually. Okay? In brain injury, there's often some degree of bleeding. There's some degree of inflammation, cerebral edema, and increased ICP. Head injuries can be very, very serious, both in terms of mortality and morbidity. And now we're hearing more and more about sports-related repeat concussions. We know Muhammad Ali's Parkinsonian syndrome is the result of all those years of getting boxed in the head. We've got football players who's now having some cognitive and behavioral and functional deficit because repeatedly being tackled in the head. Hockey players as well. So we're learning more and more about this. Morbidity means disability. Mortality means death. So especially with a massive head trauma, there's a high risk of mortality. If they live with a great degree of disability. These are the wounded warriors you're hearing about that had massive head trauma in the combat field and are severely disabled now, even though they have survived. Let's start by talking about something called coup contre coup. This is a common thing that happens in head trauma when there's a movement that all of a sudden stops or bounces off. Okay? Say there's some kind of an accelerated movement, a nasty tackle in a game, you get thrown against something, a car accident in which you hit something. So there's forward velocity, and then all of a sudden there's no. Okay, the car stops. When the car stops, the skull stops, but nobody tells the brain to stop. So even though the car has stopped, the brain is inside the skull floating on top of the spinal cord. The brain's going to continue to move forward even though the car no longer is. The brain then hits the front of the skull and then is thrown back and hits the back of the skull. So you have two areas of injury, usually forward and behind. But say if you were T-boned in a car accident, you got hit from the side, then the contra coup will be side to side, okay? It's not always, in this picture it's forward and then back, but you can also get side to side, coup contra coup. So here's the first injury, here's the second injury. It's where the brain bounces off the skull. And this is what makes it more difficult, these things more difficult to treat. These are usually acceleration, deacceleration incidents. Okay? Concussions. We used to just not pay so much attention to this. We figured that no teenage boy got to adulthood with at least one concussion under his belt. Now we have a greater appreciation that these things can be dangerous, that there are severe concussions that can be disabling, and we now know that repeated concussions are disabling, especially if there was limited recovery between the concussion. Okay? These are some of the manifestations. Cognitive, problems with memory, problems with attention. Okay? Physical, headaches that just either come and don't go or just keep coming. Nausea and vomiting, that's an early sign of increased intracranial pressure. They have problems with balance, with coordination, with dizziness. And fatigue, that's something that we're recognizing more and more, that with concussion comes fatigue for months. Okay, so when we see these athletes being put back on the field, we really got to question ourselves. Also sensitivity to light. We're seeing this more and more too. Emotional. We know that concussions affect personality and emotions. They're angry, they're irritable, they're anxious, they may be depressed. Okay? That their emotions go bouncing around too. And that they do not sleep well, or they do not sleep. Normally they either have insomnia or they could sleep the whole time. And so we never really truly appreciated this. We all said, oh, they got bumped in the head. It's typical adult boy. They'll get over it. And now we're getting a much better appreciation. What happens in a concussion is those brain fibers are stretched and sometimes mini torn, like a sprain. What a sprain is your ligaments get excessively torn to the point that there are micro tears in the ligament. Now we know that the brain fibers in a concussion are actually stretched, twisted, and damaged. It's not just getting bounced on the head. And they can be graded 1, 2, 3. Depends upon some of the level of consciousness that was lost at the onset and any kind of memory. And this is the concussion grading scheme for athletes. It's recommended for athletes. By the way, there's supposed to be a fascinating movie coming out soon called Concussion. And it's about the neurosurgeon who did the study for the NFL and then said, whoa, we got to completely change how we do this. This is actually extremely dangerous. We cannot send these guys back out onto the field. And he fought a tremendous amount of resistance from NFL leadership. So that movie is coming out if you're interested in it. Okay, so here's the grading and here's the guidelines for how quickly athletes should be allowed to be considered to go back into play. Contusion is different. Contusion is a concussion times 10. So we have damage of the neurofibers, but we also have some degree of bleeding. In concussion, you don't have bleeding, but in contusion, you have a bruise, and a bruise means bleeding. Okay? Contusions are much more serious than concussions. And in some cases, when these guys get, and ladies get really whacked in the sports arena, probably what they're not have, it's not a concussion, it's the next level up and it's a contusion. But we may be treating it as a concussion. And so now we're recognizing that there is a difference and that folks who do have a contusion should never be allowed to go right back out onto the field without an adequate period of recovery. So where there's where there's a bruise, there's bleeding. Where there's bleeding, there's increased intracranial pressure. Symptoms are similar to a concussion, but more severe and more lasting in duration. Okay. Their problems with cognition is worse. Their problems with headache is worse. Okay. So similar symptoms as concussion, more pronounced in intensity, more pronounced in duration. And if the force was hard enough to create the contusion, you better believe there's a coup contre coup going on. So they probably have 2 areas of damage, 2 areas of bruising, 2 areas of bleeding. So these folks can be very seriously affected. That head injury may be so bad you actually have pockets of hemorrhage. And there's 4 kinds of hemorrhage. Okay? Epidural hemorrhage, meaning there's arterial bleeding. I've underlined the important things, okay? Arterial bleeding between the skull and the dura mater, which is the lining of the brain, the outer lining of the brain. So blood is going between the brain and the skull. That's space occupying. So you're going to have increased pressure, compression of brain tissue. These guys can be very severely affected. Okay? This is the scariest of all the hemorrhages with brain trauma. This is the most scariest. And the scariest thing about them is that they get whacked on the head, they get a little dizzy, then they're fine, they claim to be fine, you think they're fine, and then you find them dead in the bed. Okay? This is the Natasha Richardson situation, Liam Nielsen's wife, who had a skiing injury in Canada, I think, hit her head, was fine, just said, I'm going to go back to the hotel room and lie down. By the time they found her, it was too late. So this is the scary one. And it's scary because it's an arterial bleed, it's space occupying. So with an arterial bleed, it's going to keep pulsating into that space. They're going to deteriorate quickly. And by the time you find them, there may not be an opportunity to recover them. So this is the one that you really worries the dickens out of you. Okay? So arterial bleed, residual deficit, and then here, brief loss of consciousness, they regain consciousness, they lose it again, and in many cases they do not regain it. Okay? Be right with you. The subdural is, so with the epidural, you're above the dura. You're between the skull and the dura. But with the subdural dura, you're between the brain and the dura. Okay? This tends to be a venous bleed. It's a little bit, you can control this a little bit better. This is the example of somebody who's on an anticoagulant for AFib, who falls and whacks their head. Okay? Whacks their head to such a degree that some of the small veins are torn and ripped, and they experience a subdural bleed. Okay? Often a history of anticoagulant plus minor trauma. These folks, it depends upon how big and where. These folks have a tendency to seize. Molly, did you have a question?
Yeah, so if the patients, like, originally are saying that they're fine, would they just, like, feel like they had a headache?
They're fine, they feel shaken up, a little dizzy.
Okay.
But this is why paramedics say, yeah, let's bring you in and get you checked out.
Okay.
Then they do a CAT scan or an MRI, and they see, and then they may take them to the OR. If Natasha Richardson had been taken to a referral trauma center, she would have been in the OR and she would have been alive.
So the patients aren't going to, like, experience any symptoms that they could?
Well, they feel like, they got whacked, they got a concussion.
Okay.
But I'll just go to my hotel room, I'll lie down, I'll be fine.
All
All right. Okay. So here's an example. Epidural, arterial, between the skull and the dura. Here's your dura. Okay? Lining over the brain. So arterial bleed, fastly accumulating arterial bleed. Okay? Space occupying. And it's because it is arterial and it's a fastly accumulating bleed, that's why when their level of consciousness takes that nosedive, it's quick. Okay? Here's your subdura. It's underneath the dura. It's too space occupying, but veins are slower, veins don't pulsate, so the bleeding is more of a steady oozing, but it is space occupying. Okay? Okay, and here's the dura here, and here's the skull. So you are subdural, you're underneath the dura, you're between the dura and the brain tissue. But this will be slow to develop. This one will be rapid to develop because it's arterial. Make sense? All right. Then we have subarachnoid and intracerebral. Okay? Subarachnoid tends to be one of those arterial venous malformations or an artery. You're bleeding into the subarachnoid space. Brief onset, okay, headache, stiff neck, nausea and vomiting because of the increased intracranial pressure. All of a sudden you've got blood that's just kind of ruptured and been there. Okay, neuro deficit. This one is the serious one. This is blood bleeding within the brain tissue itself. This is unfortunately often the case of somebody with extreme hypertension who is not compliant with their therapy, or they're not on the right drugs, and a vessel just pops. Okay. This is a critical situation. I think this makes sense. Okay, here intracerebral hemorrhage, and that could be a hemorrhagic stroke, for example. Okay, this would classify as a hemorrhagic stroke. And here's your subarachnoid. Okay. In terms, I think for NCLEX, I think the biggest thing to remember is the difference between epidural and subdural. That the epidural patients need to be ruled out, they need to be scanned and then monitored. And then if they scan in for an epidural, they need to go to the OR, and then otherwise they need to be very closely monitored. We have time for a couple more. Brain tumors. Brain tumors can be benign or malignant. Unfortunately, we haven't made great progress with malignant brain tumors. They're difficult to treat. They don't respond to chemo well. They don't respond to radiation as well as we like. And when they develop, they are rarely encapsulated. When they develop, they tend to have a lot of branches and tiny feet that go out and just kind of root themselves in the brain tissue. And that's why it's very difficult to fully resect them out. They're not as encapsulated as other tumors. So what you see is a surgical debulking. I'll remove as much as I can, and then I hope to get the remaining stuff with radiation and chemo. I'm hoping the day will come that we've got a drug that will be more effective in brain tumors than we have now. They are space occupying, so we're going to have problems with increased intracranial pressure. They can then, as they grow, they can compress blood vessels. They can compress brain tissue. Seizures are common. Remember Senator Ted Kennedy's, the first symptom he had a brain tumor was he seized in the Capitol building. And your treatment, it's difficult to surgically resect them because they have so many of these roots. They tend to do a debulking and then follow up with radiation and chemo. This is an example. Okay? You can have tumors on the periphery of the brain that compress the brain, or you can have tumors that develop within the brain tissue itself. You might be able to do some degree of resection here. This one would be difficult because, you see, it doesn't have specific borders to it. It's got edges that go everywhere. And you look, as this becomes large, you're going to start compressing your ventricles, and then you're going to have increased intracranial pressure with the risk of then some herniation. Okay. Signs and symptoms. Typical increased intracranial pressure signs and symptoms. Headache is common, and then there's a buildup of headache, and just when that headache can no longer be tolerated, they tend to have projectile vomiting. And if you have not, once you see projectile vomiting, you'll really know how bad it is. Okay. My first pediatric patient was a 10-year-old with an astrocytoma up in New Hampshire. And that kid vomited from the bed and hit the wall. It was like something out of The Exorcist. I had never seen it. And then he felt better and he went to sleep. Okay? So it's not so much vomiting, it's the projectile vomiting that's very classic of increased intracranial pressure. Changes in speech, changes in swallowing, definitely problems with balance or walking. They can start off with a behavioral personality change, memory, they definitely can seize. All of this depends upon where is that tumor and what is it leaning on and what is it compressing. Most tumors, what we try to do is get out as much as we can with surgery. That's called a surgical debulking, and which involves a craniotomy. Craniotomy means I need to get inside your skull to do something on the other side of the skull, usually to do with your brain. So it means I'm opening up the cranium, which is your skull. And these are just some guidelines for post-craniotomy care. Usually they come back with a C-shaped incision, okay, because they do a C-shaped skin incision and then peel that skin back, and then they have to cut into the bone. They need to take a chunk of the skull out of position. So freely resect the skull, and then depends what they're going to do with that skull. If there's been any kind of increased pressure, they're not going to put that bone skull fragment back into place because things are too swollen. So they tend to embed it in your abdomen tissue. And then when things kind of settle down, they'll cut it out of your abdomen tissue in the OR and put it back in place. Or they'll put a plate. But you just can't have a piece of skull unprotected. The brain's unprotected. There's maybe a plate, or sometimes these kids have to wear these protective helmets, because otherwise you're having just skin over brain, and that's not going to help should they fall. So when they come back, you want to know, what did they do with that skull flap? Did they put it back in position and wire it back into position? Did they put a plate instead? Did they not put anything and need a helmet? Or did they embed that skull fragment into the belly? I have had craniotomy patients come back to floors if it's like a neurosurgical floor of a tertiary medical center, and they're stable. They can come back to the floor. In a community hospital, whether they should be doing craniotomies is another thing, but ideally in a community hospital, probably an ICU setting in which you monitor them carefully. The head of the bed is always up. You watch intake and output. You control their blood pressure and their heart rate. Okay? You don't want these people jumping out of bed. You want, because there'll be some degree of swellings. So you want activity limitations on them until some of that swelling goes away. Cautious use of narcotics. These are the folks that get Tylenol only for post-op pain, because the first sign of any trouble with these folks is a subtle change in level of consciousness. You need to be able to monitor that, so you don't want to mask it. You don't want to give them a sedative or a narcotic that's going to change their level of consciousness, because if something's going on, you'll never know about it. So these are the guys that are given, unfortunately, 2 extra strength Tylenol. At the most, maybe 1 Percocet, but that's about it. Or Darvon or something like that, okay? You don't want them retching to vomit. You don't want them straining at stool. You don't want them moving around, any kind of Valsalva, because that's going to increase the pressure, intracranial pressure. And they're on seizure precautions initially because of the risk of inflammation. I think what we're going to do is cut it now, and I'll narrate these things, starting with spinal cord injury, and post them, okay? All right, if there's any questions, I'm around. Those who want to join me and practice some questions, I will be up in Gowan 200, okay? And make sure you sign the attendance sheet, folks, okay?